Good morning, everybody. My name is Jemima, I'm of the first year fellows, and I will be introducing Dr. Raman for our grand rounds lecture today. Um, she serves as a vice president for Heart and Vascular Services and chief scientific officer for OhioHealth currently. She completed her medical training in cardiology and graduate studies in electrical engineering, especially focused on artificial intelligence and computer science at the Ohio State University, where she served on the faculty for 17 years and she held the Joseph M. Ryan Chair. She contributed development of nationally recognized clinical research and training programs, especially in cardiovascular MRI and CT. We are grateful for her expertise on this topic today and look forward to learning from her. At the end of this lecture, we will leave time for questions. Please submit your questions via the chat function on Zoom as they arise during the talk. We are also pleased to offer both CMA and MOC credit for our Grand Round conference series today. To claim the credit for today's session, text the code SHAM at the beginning and at the end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud/cme.com or contact Shannon Winston. Now I will turn it over to Dr. Raman. Thank you so much. We are looking forward to hearing from you right now.
Thank you, Dr. Rezia, for the kind introduction. One of the upsides, you can reach a lot of people virtually through this mechanism. As I'm getting over a bit of a flu situation, it doesn't have to be a super spreader event. So glad to be on the screen with you today. So I'm going to talk about atherosclerosis and diabetes and kind of see if we're doing right by patients and treating risk, or if we should look at disease. I have no disclosures. Oops. Let's start with a patient. This is a 63-year-old administrative assistant with diabetes for 17 years. Rather sedentary, but she says she doesn't have any symptoms, but was concerned about her family history. Her mother has diabetes and died suddenly at age 59. She's on a fairly aggressive lipid-lowering regimen. You can see her A1C is well controlled with insulin and empagliflozin as well as metformin. Her labs are shown there as well. So you could say, what is her risk of an atherosclerotic event? And maybe you've got a favorite risk calculator. Maybe you go to the ASCVD risk estimator and you try and plug in her data, but the cholesterol level is too low. And even her LDL is too low. So that doesn't compute. Maybe you've become a fan of the American Heart Association's Prevent calculator. Well, unfortunately, we run into the same problem. So in terms of having a discussion with her about her risk of an atherosclerotic event, we struggle a little bit with the results here. But, we saw that she's got good glycemic control. It's on like you saw, a very aggressive lipid-lowering regimen. Is there any reason to change management to reduce risk? And Dr. Razzie, I might pick on you as I think a lead fellow here. What do you think? And there's no right answer. Do you think, well, her risk factors are well controlled, stay the course? Maybe there's room to change. We should do a stress test, or perhaps atherosclerosis imaging would be informative.
I will go by C.
C, okay. All right, so we've got one potential interested candidate for atherosclerosis imaging. And I will say, this is all, as I said, not a right answer, but an opportunity to discuss new ideas. So let's see where that takes us. So we'll look at the burden of atherosclerotic events in diabetes. We'll look at how we can assess risk versus measure disease, and then critically assess the evidence that we need to treat disease, not just risk factors. I'll start with the obvious. Diabetes is terribly common. Virginia and Ohio look very similar in this regard. And this is true not just across our country, but worldwide. Significant burden emerging and growing burden of diabetes. And we know through excellent mechanistic studies that different aspects of diabetes, from insulin resistance to hyperglycemia, can fuel atherosclerosis, contributing to smooth muscle cell activation, endothelial dysfunction, and particularly inflammation that drives foam cell formation, macrophages, and ultimately the proliferation of potentially unstable plaque. You can see the good news. This is data showing the reduction over time in rates of ischemic heart disease, stroke, heart failure, and lower extremity amputation in diabetics. But still, it looks like we're kind of stuck, and I'll note this is all pre-pandemic data, probably hasn't gone down in the last few years. And what's particularly concerning in diabetics is the trend towards people of younger age. So this is a graph showing myocardial infarction. Note the extra stress on women with diabetes compared to men in their 30s, 40s, and early 50s. However, given all of that data, we've stopped using the term that diabetes is a coronary disease equivalent. And why is that? There's many reasons. Here's data from Muhlstein and colleagues that did CT coronary angiography on a group of patients with dysglycemia. And you can see just from the spread of calcium scores, the distribution of stenotic lesions, and the descriptions of any types of plaque, that the disease burden was actually quite heterogeneous. And so if you read the most recent AHA heart disease and stroke statistics, you'll see a line that says diabetes is associated with great heterogeneity and risk of CVD. And in many individuals, the risk is not equivalent to those with pre-existing disease, emphasizing the importance of risk stratification in individuals with diabetes. So now let's look at how we measure risk and how we might measure disease. Let's take a look at the ASCVD risk calculator that we started with. This was derived from pooled cohort equations that work especially well for non-Hispanic whites and African Americans. You can see there were 4 cohorts that they used. Excuse me. The CV Health study, Cardia, the ERIC study, and Framingham. The estimated risk is one of myocardial infarction, coronary death, or stroke, but it has its limitations. If you're at a higher socioeconomic status, your risk can be overestimated. Likewise, your risk can be underestimated if you are coming from a lower socioeconomic status. Patients from different Asian ancestries may have over or underestimated risk. And if you have inflammatory conditions or HIV, these are conditions that are not adequately accounted for. In addition, as we saw in our patient, extremes in lipid levels, or even younger or older individuals don't get the benefit of this particular calculator. How does AHA Prevent do? Well, you can see quite a bit more data, over 3 million individuals in the derivation data sets, as well as another 3 million in the validation sets. Key to the difference in this calculator is the removal of race as a variable. You can enter as young as 30 to have a risk estimate computed. It acknowledges renal dysfunction, so you can dial in GFR and even, excuse me, urine albumin, creatinine ratio, A1C, and even zip code for social deprivation index. When this was applied to an NHANES cohort, almost 1 in 5 would have been reclassified for eligibility for hypercholesterolemia treatment. let's just take an individual. Here's a 60-year-old male with diabetes, total cholesterol 120, and through the ACC-AHA risk estimator, about 1 in 10 chance of an ASCVD event. Plug the same data into the AHA prevent calculator, and it drops to about 1 in 20. So as we have discussions with our patients about risk, we should be mindful that, how someone receives a 1 in 10 chance of, let's say, a heart attack versus 1 in 20 may differ. How about our endocrinology colleagues? We would hope they use the exact same data that we do. Not always the case. This is from the American Academy of Clinical Endocrinologists and American College of Endocrinology, that really focuses on kind of looking at all the factors, not so much a quantitative approach, but trying to classify in terms of risk category. They do take into account things like heterozygous familial hyperlipidemia, family history, CKD, and even coronary calcium. A missed opportunity, perhaps. This came out in 2017. Our ACC-AHA pool cohort data came out in 2013. Doesn't seem like this showed up on the endocrinologist radar. How about the American Diabetes Association? Well, they've got a great app that you can download that's shown here, different sections, one of which is dedicated to cardiovascular disease and risk management. And I'll draw your attention to this algorithm that describes what they classify as high risk for atherosclerotic disease. High risk includes those with end organ damage, such as LVH, retinopathy, or again, multiple risk factors. This is, of course, quite different from what we might do. But if this app is easily accessible to your diabetic patient's endocrinologist, again, the discussion about risk reduction and prevention may be different. And then it does get a little more heterogeneous in terms of what we do about it. So Kelsey and colleagues put this comparison together of type 2 diabetes guidelines. And generally speaking, you'll see some similarities in terms of 150 minutes of moderate intensity activity per week, blood pressure less than 130/80, although less than 120, recommended by the U.S. Preventive Task Force. But there are some differences in how risk stratification is done, what the treatment targets are, and as we see more diabetes medicines that can have cardiovascular benefit, heterogeneous recommendations around SGLT2 and GLP-1 agonists. So now back to our provocative question, should we measure disease, not just risk? Well, let's look at potentially rationale to do so. First, of course, it doesn't preclude our ability to measure and treat risk factors. That's the foundation on which this can be considered. Second, if we think about risk factors, they vary over time, right? So if we do some test for disease, perhaps it can be like an area under the curve that says, over the course of varying glycemic control over many years, different degree of lipid and blood pressure management, what has the cumulative impact been? It can overcome some of the limitations we saw in population-based estimates, where particularly an individual patient can differ from the cohorts used or has other conditions. And this is where we need to be cognizant, where our risk prediction calculators haven't fully captured things like fatty liver, air pollution, psychosocial contributors, and genetic determinants, which we are increasingly recognizing as important drivers of cardiovascular risk and disease. Let's take a page from cancer, as Dr. Huntley is very familiar with. We don't wait for symptomatic breast cancer, right? The U.S. Preventive Services Task Force recommends biennial screening with mammography for women aged 40 to 74. Why? Because it reduces death. There's a 15% relative risk reduction in breast cancer mortality. The presumption, of course, is that an abnormal finding leads to appropriate follow-up of results. So it's not just the test, It's what we do with the results of the test. How about our colleagues that take care of our patients at risk of colon cancer? They've further identified that we need to tailor follow-up to the disease burden. So let's go back to the U.S. Preventive Services Task Force. They offer a variety of testing options, be it stool-based, colonoscopy, CT colonography, et cetera. And they also define ages below and above which testing may not be impactful. The American Societies of Gastroenterology further detail the follow-up according to the stage of disease. So if you had more than 10 adenomas on your initial colonoscopy, you should come back in a year. You can see the burden of, we'll call it subclinical or precancerous disease, dictates when you should come back for follow-up. So we also have ways to detect and quantify coronary disease. Let's start in the cath lab. Of course, catheter angiography is a standard part of our interventional team's armamentarium. And when combined with physiologic measures, it helps make decisions about revascularization. Intravascular imaging in particular gets us at the disease burden, the plaque burden, things like intravascular ultrasound that can guide PCI planning, optical coherence tomography based on near infrared light absorption. And it's not used, but I like to mention it for obvious reasons, Raman spectroscopy. That's actually a scattering technique that gets more at the biomolecular composition of plaque. Again, helpful if the patient's in the cath lab. Let's think about non-invasive alternatives such as ultrasound. Carotid intimal medial thickness can certainly be measured. It's available. There have been many population scale studies gaining interest of this approach. Although in practice, I'd be interested to hear others' perspectives. I've seen it in specialized labs dedicated to either wellness programs or screening. And it's not in the coronaries. We can talk about the representative ability of looking at one arterial bed versus another. But this was interesting from Denreuter and colleagues that was published in JAMA that said, how well does adding CIMT to Framingham help reclassify? And you can see for the vast majority, essentially no change in risk reclassification. Magnetic resonance, obviously a big fan from a cardiac standpoint. No ionizing radiation, and for many years people have been pursuing molecular imaging with unique contrast agents. I show this picture because it made me chuckle. So the original figure came out in 2000, and then in a recent review in 2016 on update on coronary imaging with MRI, it's the exact same figure. So as much as I admire those who have dedicated so much effort to try to image the coronaries with magnetic resonance, may not be the best strategy. There's certainly other modalities such as PET with, again, the molecular basis of imaging that is very exciting. Would combine it with CT. Perhaps some complexity here in terms of the scan procedure, and access is not it is not trivial for this modality as well. Calcium scoring, widely available, no contrast, based on the simple principle of attenuation of calcium relative to water, quantitative, potential downsides, insensitive to non-calcified plaque that's more likely present in younger at-risk patients, and less predictive of events in older patients. It's also worth noting in the context of our discussion around diabetes that the so-called warranty period, the power of a zero calcium score, is a little bit shorter, a little bit less powerful if you have diabetes. It's worth noting that the National Lipid Association has also put out a scientific statement that is supportive of calcium scoring in different risk categories. So let's now look at coronary CT angiography. you can see calcified as well as non-calcified plaque. There are other features that we know I'll look at with you in a minute in terms of risk. The downside, of course, IV contrast. Most systems now require some effort with heart rate control, although that could be changing with future technologic breakthroughs. This has been around, again, for a while, that we can see not only stenosis, but low attenuation plaques and positive remodeling. Here you see a patient actually took care of a few years ago, a physician who was having kind of shoulder pain walking through the airport. And this right coronary lesion was very concerning. Again, just that positive remodeling that you can actually measure in the plaque. The arterial wall expands to accommodate the plaque, making it more vulnerable to rupture. He actually had an inferior STEMI. He recovered well a few weeks later. This is from quite a while ago, but this has been borne out by subsequent studies showing that you have these features of positive remodeling, low attenuation, have a significant predictive value for events. Now, just measuring that positive remodeling manually, probably within reach, but to measure, I'll be right back. Yep. Okay, so you can't do this manually, right, throughout the coronary tree. Now there's AI software that honestly makes it easy. And the disruptive advance here is the notion, just as we saw with colon lesions, we can stage the burden of coronary atherosclerosis. I think if you look at this coronary, it looks pretty clean. Here you have some mild disease classified as stage 1, a little bit more in stage 2, and then a heavy burden of plaque in stage 3. And this is from Nur Mohammed and colleagues, showing using the staging classification really does impact prognosis. So it gives us the notion that staging the burden of coronary disease helps inform an individual's risk. Okay, so now let's look at what's missing, what evidence is needed. On the one hand, treatment options are considerable. We're not just talking about statins anymore. We've got, within the lipid-lowering category, a lot of agents. We've got antithrombotics, such as rivaroxaban. Colchicine has gained attention as an anti-inflammatory approach to atherosclerotic disease. And then, of course, the diabetes agents, SGLT2 inhibitors and GLP-1 receptor agonists. There is a trial ongoing, again, from Muhlstein and colleagues, called CoreCal, that's comparing coronary artery calcium scoring to the pooled cohort equations for primary prevention. They published initial results showing feasibility that found some increase in statin adherence, decrease in LDL, and similar costs in the coronary calcium arm. Ongoing is the evaluation of heart outcomes. This is a comparison of various studies, again, looking at various modalities to screen for coronary disease. You can see stress testing, myocardial perfusion imaging, CT coronary angiography. And regardless of what was used, this systematic review found that a cardiac event could be reduced significantly, and that the number needed to screen was only 56 to prevent one event over 4 years follow-up. It's worth noting in the Factor 64 trial that treatment really targeted stenosis, which, as we know, isn't necessarily the biomarker of events. You can see that they were screened, enrolled, and if they had the CCTA, again, sort of classified according to mild, moderate, severe stenosis. Scott Hart is a trial I'm sure you're familiar with, now looking at patients with chest pain. 11% of those had diabetes, randomized to typically stress testing or coronary CT, and showing significant improvement in outcomes that has shown durability even at 10 years. And the thought is that it's because the identification of disease prompted treatment. So they called preventive therapy, including statins, in some cases aspirin or other antiplatelet. That was used more often in those randomized to coronary CT. I was fortunate to be part of the ACC's Innovation and Prevention Working Group, and using that staging approach, we tried to provide some guidance for clinicians who have access to this type of software prior to randomized trials, giving us a formal guideline document. Here, imagine you're talking to your patient and there's absolutely no atherosclerosis. Is that an opportunity for shared decision-making discussion about de-escalating therapy? You know, are they on a high-dose statin with some side effects? If there's no disease, what are we treating? We don't want to ignore the possibility, particularly in the diabetic, that it could progress. And so perhaps rescan in 4 years. And then if disease has progressed, then treat accordingly. Stage 1 says we've got to start with high-intensity statin out of the gate, add ezetimibe, and then again, rescan perhaps in a shorter time frame with more aggressive treatment options. I won't go into detail into stage 2 and 3, but suffice it to say, these are, you kind of get to the kitchen sink approach at the end. Again, somewhat controversial. And when we put this together, the question came back, how can we apply this to patients? Because, you know, this is not just for the software, but as many AI innovations come through, it sort of comes ahead of the type of evidence we rely on as clinicians to decide about, does it really help the care of my patient? Payers at the time were not covering this. Providers said, we want this in our toolkit. And there were some patients that had heard about it that wanted to know if they could get this type of CT with AI quantification done. So the health plan, this is work that I did when I was at OhioHealth, said, let's do a pilot. So the health plan paid for this analysis to eligible patients. And just to remind folks, if you've not worked in this space, a health plan is essentially taking risk on its covered lives. So this can be, you know, this is the case for employee health plans, Medicare Advantage, and other value-based contracts. And so through the pilot program, the health plan offered coronary CT and an AI analysis to any covered life 40 and above with diabetes. Again, not dissimilar from a health plan benefit of colonoscopy or mammography that you might sign up for. Now, what did we look for in terms of outcomes? Well, a health plan benefits manager has a bit of a shorter time frame to see return on investment than, let's say, a typical clinical trialist. So they kind of stretching it at 2 years because most employees may be on a different insurance plan, you know, within, I think the average is less than 5 years. So they were keen on seeing what is the impact of enrollment in this program, how many people actually use it, and then if they enroll, what happens to our healthcare expenditure afterwards? You know, does finding disease suddenly incur a significant amount of downstream cost? It was also fun to take this initiative and use it to grow access to cardiovascular CT. We talk about access to colon cancer screening, mobile mammography. And so we were able to stand up some CT locations, rural, urban, and suburban across Indiana to give employees across this health system access. The workflow was very carefully thought of in partnership with health plan nurses and managers. So once a health plan member received a letter, they got the phone number for customer service to contact and enroll. Typically, a utilization management nurse would also ask if they were interested in our biobank study, where if they came in, they would get some blood collected at the time of the CT for research purposes. And then they would tee up the orders for the CT and any pre-medication that was needed. Once the CT was scheduled, the AI analysis completed, 2 reports show up in the electronic health record. One is your typical clinical report, which also includes a lot of the quantitative data from the AI analysis. And then there's a lay language report, which we'll look at together. That's available, again, once the report is finalized, immediately available to the patient. The ordering clinician, which is typically the primary care provider, arranged a clinic visit, typically a cardiologist or a nurse practitioner. And all the participants were encouraged to review their lay language report before coming in. This really I saw a lot of these patients myself, made for a very engaging discussion. They would point to something in the report, and it's just a very nice foundation of knowledge, empowering the patient. And then shared decision making to develop a treatment plan if there was any disease identified, follow up with their primary care doc, and then any follow up with the program. So here's the lay language report that I talked about, written at a 7th grade reading level. The first 3 sections go over some very basic information about coronary disease, risk factors, and the analysis. You can see it goes into great detail about different types of plaque, and sort of this good news slide that you can do something about it. We have, of course, data that shows treating atherosclerosis impacts the disease itself. And so after going through this education, they can then see their coronaries. Again, okay, now I've learned about the disease, what's in my heart, and that's readily available to the patient. So we screened a little over 38,000 health plan members over a pilot period of 14 months and found a little under 1 in 5 utilization, which I'm told is not bad for a new preventive offering. Those who utilized the pilot were more often white, female, and residing in an area of higher income. And you can see, as we saw in the earlier studies, a heterogeneous distribution of disease. A lot of folks with mild disease, but some with more severe burdens of coronary atherosclerosis. And in summary, this is in review. What we also did a matched 1-to-1 analysis of utilizers and non-utilizers, a slight uptick in subsequent episodes of atherosclerotic care. But when we compared per month, per member expenditure for glycemic control and ASCVD risk, it actually came out about the same. We would expect patients with more severe disease to incur higher healthcare costs. And so, again, longer-term follow-up is needed, but this was, I think, at least an interesting step forward. We also, from the biobank samples, were able to look at lipoprotein a. The results showed high levels, but again, heterogeneous. The LP(a) levels indicated non-calcified plaque, but not necessarily plaque progression. This is a subset that had a follow-up scan. And so, as we've seen trials now that show we can treat elevated LP(a), is this an opportunity then to use direct measurement of the disease to refine patient selection and follow-up for targeted drug therapy? So back to our patient, you'll recall she's a 63-year-old female with diabetes, concerned about her family history, who is on very appropriate lipid-lowering and diabetes therapies. She was a member of the OhioHealth plan and enrolled in this pilot. As you can see, she had quite a bit of atherosclerotic disease. That was a surprise to her, but she was very grateful for the recognition. Stage 3 per the classification we saw earlier, but no significant stenosis. Not huge changes, but it prompted addition of ezetimibe to her medical regimen. And perhaps more importantly, she really took seriously the opportunity to take advantage of health plan coaching resources. So nutrition, physical activity, major motivator to get moving, so to speak. And the good news is about a year later, her weight was down, blood pressure improved, and plaque burden relatively stable. So still significant, but stable plaque. We do need randomized trial evidence, and the Paramount trial has started. This is in symptomatic patients with suspected coronary disease. They'll be randomized to usual care versus the AI-enabled quantitative coronary CT plaque-based care. And you can see the primary endpoints, secondary endpoints as described there. Heart 2 is picking up the baton as well, looking now at asymptomatic patients with one or more risk factors, one of which, of course, could be diabetes, that are randomized to usual care versus CCTA-guided management. Interestingly, we talked about risk scores. Scotland has its own risk score called a SIGN that's derived from the Scottish population and includes risk factors, social determinants of health, and family history. And then Transform is kind of intriguing, specifically in diabetes, sponsored by Clearly, the manufacturer of that software that I showed you. Of course, the pharmaceutical companies, colchicine, bempedoic acid, sotagliflozin. I haven't seen it on clinicaltrials.gov yet, but I think it's underway. What kind of piqued my interest was one other sponsor that was listed called Heartbeat. I said, who's Heartbeat? What do they do? They're a company that is expert in marketing to patients. So as we think about where is the early detection and prevention space going, medicine in general, there are so many disruptors outside of our traditional bricks and mortar health systems. I thought this was interesting. So look forward to discussing some take-home points for consideration, that atherosclerotic disease burden and event rates are significant but heterogeneous in diabetes. Estimating risk depends a little bit on the risk estimation tool that you're using, which in turn has implications for treatment and outcomes. We can also detect and measure disease burden, and ongoing randomized trials will hopefully inform if and how we are able to treat disease, not just risk, to mitigate the event burden in those with diabetes. And I'll leave with a plug for population health as a platform and health plans that may warrant greater consideration in atherosclerosis disease management. Thank you.
Thank you, Dr. Raman, for this great talk. Very interesting. I'm just checking the chat box if we have any questions. And if anyone has any questions, they can unmute themselves and then ask as well.
Yeah. Well, Subha, thanks so much for this really thought-provoking talk, and also your Michael Jordan-esque battling through giving grand rounds when you're recovering from the flu. Really appreciate that. There's a new CT technology, this photon counting, that allows one to appreciate sort of the severity of stenoses, both within those that have had, intracoronary stents planted, and also those that have extensive coronary artery calcification. I wonder, have you worked any with that technology, and would that impact any of the appreciation of how disease may be responding to the implementations of therapies that are going to reduce risk. So for example, you showed in your example that this particular individual that participated in the coaching had a lowering of blood pressure, reduction in weight, but the plaque burden was stable. Are you able with this new technology to differentiate, has the sort of quote unquote soft plaque converted to the calcified plaque, or how you might implement? So it's kind of a two-part question. What's your opinion of this new technology? And two, would it be valuable to understand how one's atherosclerotic burden and its morphology may be changing over time?
Thanks, Greg. Again, very much appreciate being here with your team. Wonderful questions. Let me start at the end. The patient, you're right. She had significant plaque. It was stable, and I didn't point out, but the calcified plaque component increased, as we know can happen with plaque stabilization. And it's, I can just say the angst, the fear that she had given her family history, to be able to see the disease, and feel like she was doing something about preventing something like that from happening to her. I mean, huge impact at the individual patient level. Tracking disease and response to therapy, I think it's overdue for us in the coronary realm of cardiovascular medicine. I think we do a reasonable job, in folks with myocardial disease. Maybe get follow-up ejection fractions and so on to look at response to therapy. I can't tell you how many patients have asked me over the years, I've seen post MI or post PCI. Well, how do I know, the whatever statin you have me on is the right dose, and that I'm not going to have something else happen? And I, for the most part, have kind of shrugged my shoulders, right? And, we've all seen patients who have a recurrent event, and we think, well, maybe this is somebody who just needs longer antiplatelet therapy. It feels a bit, I'll use the analogy of phrenology. The ancients felt the bumps on the head. And I think we're very early in terms of our personalized approach to tracking and treating atherosclerotic disease. And then your first point about photon counting CT, I think, is a very, very interesting one. Certainly gives higher spatial resolution, better tissue contrast, less noise, and, for patients, lower radiation exposure. It will be a game changer in many respects. One of the Achilles heels, if you will, of current clearly or other based approaches is you can't see through stents. So that's where we need to be able to see, and perhaps photon counting will get us there.
Thank you.
We have one question from one of our fellows, Raj. He's asking if Clearly analysis shows plaque progression in 5 years despite lowering LDL, how should we proceed?
Thanks for that question. I would say this is where I'll call it guideposts that the ACC Innovation and Prevention Working Group published. That's under Andrew Freeman and colleagues in the American Journal of Medicine. Gives you next steps, based on plaque progression, that, again, it's more than just lowering LDL. Now you really need to say the disease is something that I need to treat. And many options, and we don't have randomized trial data yet, but this is where I think increasingly technology gets out there. It looks promising. Maybe patients have access. It's, instituted in different health systems. And so that Freeman et al. Paper is really intended to give people a little bit of a roadmap as to what to do pending randomized trials.
I do have a question as well, Dr. Rahman. You mentioned the AI software you use and how this enhanced this routine CTA imaging and what additional benefits does it provide in terms of accuracy, and diagnostic capabilities.
First, I have to say it's a huge boon to the CT reader. Obviously, it gives us a lot of information for patients, but if we think about the time for those of you who are involved in coronary CT as a clinical service, it's not, it's not an insignificant effort to thoroughly read an exam. This makes it a lot easier, and I think we've seen this in other imaging and even other domains where we of course have to check and be cognizant of errors and other pitfalls. But from a reader standpoint, this has been, I think, very, very helpful. From a patient standpoint, again, it's how do patients have access? How do we work together, with payers, with systems to get access to the right patients? And that could be, again, through a health plan, like what we tried. Now that there's a coding mechanism for this, you can offer it clinically. I think it's worth some proactive thought, get the right stakeholders around the table to say, if we offer this, how do we get the right patients in the door and make sure that they have the right guidance after the scan? Again, that cancer analogy, right? The mammogram saves lives only if you do what's right after the scan.
Yes. Thank you, Dr. Rahman. We have another question on the chat asked why coronary artery calcium scoring is less predictive of CAD in older people.
Yeah, I think that's a great question. I'll take a page from serial IVUS data that shows statins. I'll avoid the term saying regress plaque. They stabilize plaque, and you'll see more calcium in the plaque. This has also been borne out in serial CT exams. Calcification seems to be a biologic mechanism of plaque stabilization. And so if you've made it, let's say, to 80, and you've got a significant calcified plaque burden, maybe you will die with coronary disease, not of coronary disease.
Thank you.
Of course, now my cough is completely resolved. So.
Okay, if we don't have any other questions, I think we can wrap up a little bit early. Thank you so much, Dr. Raman.
Sure thing. Thanks, everybody. Have a good day.
Take care. I hope you feel better.
Thank you. Bye.